So hello, my name is Dr. Stephen Hopwood. I'm a medical doctor and an acupuncturist, and I run a complementary health clinic down in Totnes, and also a little complementary cancer care centre. So I also do some filming for these events. So thanks for doing the short interview today. Would you be so kind as to introduce yourself, your name, what you do?
Yeah, sure. My name is Siegfried Trefzer, Dr. Trefzer, Dr. Siegfried Trefzer. They call me Ziggy, it's easier. It's a Swiss German name. I came to this country 25 years ago and worked in the NHS and have learned all my clinical skills in many different hospital settings, worked in primary care for many years, including complementary medicine at the Hospital for Integrative Medicine in London. And have always been somehow hugely intrigued and curious about medicine, wider aspects of medicine, and how it could be perhaps improved. But also was kind of like at times disappointed that about the results I saw or I'm seeing that the boundaries could be pushed a bit more to how to improve results, and particularly in the spectrum of chronic illnesses, or once patients survive just the acute crisis and experience some of the wonderful NHS treatment, the follow-up is often where the guidance in the follow-up phase is where there's input lacking, and it's a grey zone where you either become ill again or you become self-motivated to pull out of that by patients search around, they find clinics abroad, they find clinics like ours. We've set up a clinic for this purpose to kind of provide guidance and expertise. And one of them is also in the field of complementary cancer care, which includes many other aspects. It includes musculoskeletal medicine, it includes nutrition, it includes psycho-emotional aspects. Excuse me, and the hormonal aspect is also quite important. I heard that there might be even an interest in discussing the thyroid aspects and how the hyper and hypothyroidism impacts on creating a terrain which might be favorable to develop malignant diseases. And that is, I think that is often kind of not looked at in depth, not in the developing stages, or where the warning signs could be taken more seriously in order to prevent it in the long run. And one of them is hypothyroidism, which is only partially examined properly by the routine tests, which are focused on TSH measurements, and if TSH is in the normal range, it means there is no problem. But if one looks at the whole spectrum, there are often a range of problems. One also looks at the measuring body temperature, which some clinicians rate as the most scientific test, as a series of morning body temperature readings that will then indicate whether you're in the hypo zone or the risk zone or the in-between sphere, and whether to take any interventions or not. And to match that with how people feel, they often feel not on top of things, they feel lethargic, they always feel cold, they can't be motivated easily only with a lot of stimulants. And these are all little signs that something might be metabolically wrong, or could be addressed, or could be improved.
Yeah, no, I absolutely agree. I think that's really what I'm very interested in right at the moment. I think that's quite core myself, and so very pleased to hear you say that. I'm quite interested, actually, if I may, to ask more specifically about TSH, T4, T3, and reverse T3, and what your understanding of those tests are relevant to optimizing thyroid function.
Yeah, certainly, a very good question, because I think to get a full picture, you have to, as I just said, you measure you get temperature readings, then you include the full spectrum, including thyroid antibodies, but also include T3 I think as an important component. T3 is the active part of the thyroid hormone, and if the conversion from T4 to T3 is somehow blocked, then you cannot access your fuel. You're just running out of energy throughout the day, and clinically they say the tests are normal, so it's, and then you might be called in the second or third wave diagnosis as being depressed. And that is scary. If there's something you can do about it, so why not doing an extra bit of testing? And patients don't mind. They pay the extra £25 that it costs to do a T3 analysis or a reverse T3, and that gives often clues. It motivates them to because there are avenues how to influence and how to treat it. Looking at cofactors that help the conversion from T4 to T3. Look at environmental factors which might even block or might even cause a mimicking effect or cause offset the whole feedback loop. So they could be like in the central nervous system. They could also be thyroxine type substances that can upset that balance.
Peroxidase inhibitors or something.
Yes, or drug effects of other drugs they might be taking, or just simply nutritional. There could just be lack of iodine in the diet. And iodine belongs to the same group of elements as fluoride and bromide. Fluoride. If you look at all the fluoridated toothpaste and the chlorine in the swimming pool and in the drinking water.
You sound like me. That's really good to hear.
So which element do you think is most likely to be pushed out of that?
Iodine.
Iodine.
Yeah, competitive halogens. Yeah.
Competitive halogens, and iodine is pushed out and therefore not available for proper thyroid function.
But fortunately, the reverse also happens when you have adequate levels of iodine that detoxifies the other competitive halogens out of the receptor sites and out of the body. Yeah?
Right. Interesting. Yeah. I haven't fully looked at that aspect, but it's good to hear. So that's correct. And then, but if people can do something about it, then they would certainly take it in their own hands and also then raise their body temperature by balancing the thyroid in a more raised core tissue or tissue environment in an optimized thermic environment. All metabolic functions work at a more optimized level. Digestion, protein, fat assimilation, detox mechanisms, transport mechanisms across the cytoplasmic cellular membrane into the cytoplasm. All these things matter and prevents even buildup of free radicals and toxins that in the long run could affect your health in a negative way. So if that's known, then and the cost of using antidepressants could be reduced by just improving the thyroid, improving overall performance, and the feeling of being on top of your agenda as an individual. That would be so much would be gained from that.
You get a positive feedback in a sense, because then people have got the energy to exercise and concentrate on their diet, and they're motivated to get the things together that they need to improve their health. So
correct. But there's also a lot of misinformation. They are saying
interesting.
Some patients feel health is eating, for example, switching your diet completely, not to eat anymore what your ancestors ate, to live on coconut and mango and soya and a few other things. All countries are slightly exotic foods that haven't grown in our latitude, in our environment. And so genetically we're not kind of prepared for it, not used to it. So therefore, the question is also, are these foods inducing hypothyroidism? The sudden change in our dietary regimes from one generation to the next. Can that perhaps be blamed for this kind of widespread, borderline underactive hypothermia or hypothyroidism?
I think it is, there's multifactorial causality. I think it's obvious in a sense that it's driven us into this sort of society, in a societal state where
Mm.
almost the entire society is in a state of chronic hypothyroidism. Generation.
Yeah. Another factor is the use of cheap plant oils. They have a very suppressive effect on the thyroid function.
Yeah.
And people think plant oils are healthy and therefore consume a lot of it. Basically, they have digestive problems, but consume all these oils to help to oil the food down the digestive tract, to lubricate it, but create a form of hypothyroidism in the long run.
Yeah.
It's a misconception, and that could be partially be blamed, misunderstandings.
Mm. So my interest is testing T3 and reverse T3 and endeavouring to get an optimised level of T3 and a healthy free T3 reverse T3 ratio 2 to 1. Do you know much about that sort of depth of it, or I'm still struggling for support on that level already?
Yeah, sure. I think it's to diagnose. The diagnostic side is often a bit more advanced than implementing it into efficient treatments and keeping an eye on that it stays on track. Things stay on track, and to monitor progress, and if there is failure, then not to give up on those patients. So that is an important aspect, and to mention diet, but also what can you do if there's entrenched hypothyroidism, T3 deficiency, and a lack of conversion, and failure to respond to any measures taken. So substitution of T3 is a possibility. It's even prescribable on the NHS. T3 has a short life, a short half-life compared to T4, so it's more unstable. So therefore, it's more difficult to substitute it. But there are formulas available in the NHS, BMF, pharmacopoeia, where T3 can be substituted. I think it's normally a BD or a twice daily regime. This has a short half-life, and therefore you get huge fluctuations. And thyroid patients don't like these mood fluctuations and energy fluctuations. It's horrible for them. But if they understand what happens, then they are more. They see moments of when they completely get out of this depressed state and under-functioning state, and see a bit of that daylight. That often gives them hope to to explore avenues of treating it differently, or not being dismissed in the first place. And so T3, there's also there are retard formulas or delayed absorption products that delay the what's the technical word?
Release, slow release.
The drug availability or
Is that bioidentical T3 or synthesized? Is it?
Yeah, it's a good question. There are two types. There's synthetic, there's semi-synthetic, and there's, I think the bioidentical is more or less semi-synthetic. And the sources are not always 100% clear of from what sort of like substance or animal substance is it derived from. There are a number of suppliers that provide good quality, we believe. And there are aims now to standardize it more, to reduce the fluctuations, particularly when it comes to alma thyroxine. A lot of patients that I've met over the years, they said I couldn't live life without alma thyroxine anymore. It has certainly included T3 and T4 into my metabolism in some sort of a reasonably well-matched proportion that at least I can live life easier on a daily basis. And now there's ways of standardizing that and making it more prescribable, perhaps also for within the NHS, even perhaps at some point. Hasn't happened yet, but that is just coming on the market. We've started as a clinic to experiment with it, and not experiment, but to use it and to compare it with the use of alma thyroid or the slow release formulation, which we get from the Wilson's temperature syndrome people in the US. It's a school, the endocrinologist who explained this, and explained the many aspects of hypothyroidism, how that ties in not only with with increased cancer risks, but with so many other degenerative problems of midlife in particular, or second part of your life, if there's thyroid suppression or factors suppressing the endocrine interactions. And they come up with a really good program to a point that it could even be curative. So it's like a cyclical challenge test of the thyroid using T3, using a slow release T3 formulation that in different quantities and different dosages, and they cycle up and they cycle down again. That's what it's. So it's like you go. It's a bit like sort of some patients experience going through hell and backwards, or but after a few such cycles, they feel they stabilize. They need less and less of the T3.
Okay.
And that itself says, okay, they kick-started their own thyroid again.
Okay.
So there's some tissue regeneration impulse has been created by this method. And the common story, if you start only replacing T4, let's say 75 micrograms, and then you go up to 150, and the story often ends with 225 or something. So it tends to go up rather than going down. So it's almost you block your thyroid tissue to take over and to ever fully function again by substituting it under this not enough discrimination strategy. And that's why I think I would advise to listen to experts who have pioneered and explored and put a lot of their energy into this. And not only the pioneers, also the patients who contributed to that data pool, they do it with great hope because they feel something hopefully is going to change. And I think in the long run, if we look at what disrupts the endocrine system, what disturbs it, what's wrong in our nutrition, we may need less of the spectrum of antidepressants. Or even if the thyroid overreacts and goes into a hyper condition, which can also happen as an effect of chronic depletion and continued adrenal stress, it can go the other way. And that's also a problem.
The adrenals. Can you speak a little about the adrenals in the relationship? It's often, if the thyroid doesn't show up, then the adrenals have to kick in. And if the adrenals have been, running the show, then they get exhausted. And then if you fire the thyroid up and you leave the adrenals unsupported, then that's not good. So how do you support the adrenals?
Yeah, so the two, or even several of these endocrine glands work in an orchestrated fashion. The thyroid is often mentioned, and people endocrine, it's synonymous with thyroid, but they also have forgotten adrenals. It doesn't play much of a part in Western medicine. It plays a huge part in Eastern medicine concepts. So they have nutrition programs that support the adrenals. And what we know about the adrenal, I tend to talk about is adrenaline. And a few other hormones, maybe noradrenaline is what we hardly ever mentioned, although a huge difference to adrenaline. And so we associate it with stress, or with stress we cannot cope. Some people use the word uncoping stress. I'm not sure if that's in the Oxford Dictionary, but there's a lot of that around, so it should be in the Oxford Dictionary. So stress we cannot generate as a compensatory strategy, but in the long run it exhausts our adrenals, it drains our adrenals, and then we get drained and exhausted. And we either drink more coffee, get more sugar, or use our thyroid to compensate. And so this is a scenario that has to be often addressed in the pathogenesis, and has also sometimes, if you want to ride the horse backwards, then you have to see, okay, maybe it wasn't the thyroid in the first place, maybe it was the adrenal, and it was the stress of moving house and changing a relationship and whatever. And it could be many things. And then if you balance both simultaneously, you stand even more of a chance to perhaps get it right. And I think endocrinologists who work more in this holistic framework, they tend to balance with nutrition and also addressing several endocrine institutions in our body at the same time.
Yeah, DHEA maybe is good.
DHEA could in that, or keto DHEA could in that aspect be very useful. And
ginseng, rhodiola, those sorts of things.
Herbs,
I think are good.
Right. They have a reputation for doing similar.
Yeah.
So there's either the synthetic or the semi-synthetic pregnenolone, DHEA, these kind of substances. Or if you want to ignore that, and this is kind of like all man-made stuff, let's go back to nature and get a few of these Chinese herbal kidney tonics or Ayurvedic kidney tonics. Or in Western nutrition, there's horseradish is a bit of a kidney tonic. And there are a number of substances in the herbal tradition known to stimulate adrenal energy. I think we should look more into these kind of folk wisdoms. It does exist, but we have to kind of look with a new interest again. I mean, conventional medicine uses this a lot, gives cortisone when we are in a dire situation. Suddenly we remember to stimulate the adrenals, but then it's over the top. It's the excessive cortisol and cortisone that is used and then blocks it, causes a blockage.
It's like the same equivalent as T4 in a sense, it doesn't support the organ in regenerating it.
It doesn't support the finding the balance and the finding the balance by yourself without having to see a doctor or physician to always kind of get the dosage right for you. And that is tricky. That creates a lot of pressure on the health service, on the medical establishment to get that right. It's a huge task, and it's not taught in medical school how to do this. So we doctors are under enormous pressure there, and see how half the time inefficient it is.
Yeah. So to go back to what you were saying earlier, how there's beginning to be a new understanding that this chronic hypothyroidism could well actually be, if not a causative, but a significantly driving force for a whole plethora of chronic diseases. So my understanding, I've been studying with nahypothyroidism.org, National Academy of Hypothyroidism in the States, and gentlemen over there have been doing some good work saying the same sorts of things. Mm-hmm. And they think that hypothyroidism is underlying coronary heart disease, autoimmune disease, which is diabetes, chronic fatigue syndrome, women's hormonal, menstrual irregularities, depression.
Absolutely.
Can you add any more to the list?
I think also digestive problems we should look at, certain types of anemia. So there seems to be some correlation between hypothyroidism and low plasma ferritin. Plasma ferritin is often lacking of hydrochloric acid, and it's produced by the stomach during protein ingestion or protein digestion. And if that doesn't work well, there's not the right amount of amino acids absorbed, not the right amount of ferritin or iron absorption suffers. Low iron stores and hypothyroidism are almost a little bit similar in their clinical manifestation, but I think they are they're amplifying each other to some extent.
All my female patients are now diagnosed as hypothyroid anemic unless proved otherwise, basically. I just think it's just absolutely endemic. Really.
Yeah, and when we measure these patients, we don't look at the 3 or 4 or 5 components that are part of the bigger picture. We just look at, for example, iron. It's a little bit low, but it's not low enough to interfere. So send the patient away, monitor again. But something could be done if the pattern is recognized, and the subjective feeling is feel constantly low, life has become a big stress and experience. But if you think about it, we are protected in many ways. We don't have to fight with tigers jumping out of a bush anymore. So a lot of stresses have dropped away, but we are, I think, more stressed than any other generation previously, where people had time to proper conversation, had time for their kids, and had time to relax and have fun time in life. I don't see that much in society anymore now. People constantly rush to clinics and try to enhance their performance, pushing themselves a bit harder because they feel something is not right. I'm generalizing here a bit, but it's
very common.
Anyone who's a GP and who listens carefully to the multi-signals that come in every day, and so there is certainly a pattern. There's certainly trends that we can identify, but we have to see the whole picture and not just see it in context with the environmental challenges that we face. I'm not talking about GM food; it's another discussion, but the estrogen aspect, or the estrogenization is one important aspect, and the food chain that is contaminated with xeno hormones, hormone components that create a lot of chaos in our endocrine system.
Yeah.
And I think that has to be addressed. So one has to emphasize detox. One has to emphasize healthy nutrition, use enzymes where necessary to balance before using pharmaceutical drugs, which only cover singular aspects, but do not address the metabolic pathways, right?
So digestive enzymes we talk about?
Yeah,
what sort of enzymes?
Digestive is a good way to start with. You want to start as much upstream as possible. So if you can regulate a condition with using pancreatic enzymes or hydrochloric acid, stimulate amylase, and at the beginning, at the start of your digestive system, the digestion starts by chewing your food well, then you have already created some impact. Give patients and clients homework, and they love being involved in their improvement by taking responsibility for themselves. I think we as doctors give them clues how to do it.
That sounds a fantastic approach. It's really wonderful to meet you and find somebody else that's interested in the same thing, because I'm quietly beavering away getting involved with, so that's wonderful, and obviously it seems to have taken them on a few levels as well. So where exactly are you working at the moment?
I'm still working in the NHS. I've talked about the NHS. I maintain NHS activity in the hospital in London.
Excellent.
And do GP work, do some locums for colleagues to cover when they're away on holidays, and have my own independent clinic in Sussex, in East Sussex.
Okay.
And, so this is where I also can run a lot of the laboratory assays and test profiles independently, without much bureaucracy. Have my own data collection system, and hopefully over the years can create data that make a bit of an impact, maybe in the whole health discussion.
Excellent. Would you be kind to tell us a little bit more about your clinic in Sussex?
The clinic in Sussex has started probably about 9-10 years ago, probably under some patient pressure, but also under my own, I had to acknowledge my own unhappiness with trying to fit into a system that created a lot of stress in the way I wanted to treat conditions and diseases, and myself working under maybe less time constraints, or have more time to solve problems rather than doing repetitive work that in some situations violates a little bit the need for looking deeper, or for wanting to engage into a problem deeper.
Doing the job properly.
And do a job properly.
You finish the job, the beginning, middle, and end, and
accomplish the task.
Yeah.
Exactly. So I have more freedom, although running a private enterprise generates a lot of administrative work that we as doctors don't have so much in the NHS, not in hospital doctors. Others doing it for us. So we have to find in independent settings, we have to find our own resources, and also keep out of regulation difficulties. And this has been a challenge for me, and this has been a huge learning curve. And there's a Air Quality Commission. There's so many chemical waste handling, and there's so many aspects of running a clinic that you learn as you go along, and it takes a large part. You have to employ people to just manage that aspect. Then it comes to imports of products and drugs and searching for new items one wants to use in the clinic, whether they are technical or whether they are within the supplement regime clinics provide, and that takes a large part of the sort of research aspect of to improving the quality, performance quality of the clinic. And this is we don't, as medical doctors, we don't have much training. I never knew how to fill in a check until I was qualified in medical school. I had no idea about finance and management and marketing and not doing too well at the marketing, but the patients come nevertheless, which is in itself, I think, a bit of a good feedback that on which basis I can thrive and I can carry on a bit longer. I would love to work with other clinics and other doctors who do similar things and to find work perhaps within a team of practitioners who are maybe on a similar wavelength and would like to contribute to changing the landscape, the medical landscape a little bit. And we certainly have one group within the population that supports us enormously. These are the patients that we treat. They stand up for what we're doing, and I think that's our biggest asset, really. And we have now with the empowered patients, they have more influence in health planners. So they're quite happy to stand up, to even with a bit of encouragement from us, perhaps, and giving them a bit of space, they would form patient groups to create that public voice, that informed, based on information and based on own experience, which I think should have a huge impact for the future of how we manage health. So this is what I see where I can make a contribution. My clinic has done that. Of course, every clinic has its own teething problems, and we had ours. But it's nice to be kind of recognized and to be appreciated and sometimes antagonized. It's also nice. So it's great. I enjoy this, doing this, what I'm doing. And Yes to Life is a great organization who is certainly trying to reset the goalposts and has made a huge impact. And there is a forum where people can come together and where ideas can be brainstormed and researched and hopefully move to a different level of transparency and action taking. So it's great. It's great to be part of it.
Excellent. It's really wonderful to meet you, and learned a lot already, and it'd be very nice to keep in touch and see if I can learn a bit more about how to go about balancing the system, really, because it feels like you've taken it a long way, and wonderful to have those resources at your disposal, really, to do your own assays and everything else. So thank you very much.
Thank you.